Well, good morning, everybody. Well, actually, good afternoon, everybody. It's noon. I want to welcome everybody to this briefing today. I'm Dr. Sandra Hernandez, and I'm the President and CEO of the California Healthcare Foundation. This morning, I'm actually representing all of the foundations that supported this work: the California Endowment, the Blue Shield Foundation, the Wellness Foundation, and the Gordon Betty Moore Foundation. On behalf of all my colleagues, we really want to welcome you. Whether you're in the room or you're live streaming, we're delighted to have you today. I think everybody in this room appreciates that California really has led the way in healthcare in so many ways: in ACA implementation, in coverage gains, tremendous amount of work on access. And I think everybody also recognizes that to sort of fully achieve that vision, we actually do need to stop and step back and ask ourselves, on what workforce are we going to get ourselves there? And that was really the vision that we had for putting together the commission. 24 commissioners from across the state, some of whom you'll hear from this morning. These are people who gave of their time and their energy, their expertise, led subcommittees, did a tremendous amount of work with technical advisory committees. And the way I would sum this up is really the best minds and the best science and the best evidence came together, was deliberated through the commission, and with that, we are very happy to share with you today the recommendations that came from that report. As one of the commissioners said to me this morning, this really is a strategic initiative of the state, but it's one that cannot be done by any one sector. This is really something that will require our academic institutions, it will require our hospitals, our clinics, it will require the public sector, it'll require the private sector, really to achieve the vision that's been laid out in this report. It'll take a shared responsibility for us to implement it. And so I appreciate you all being here. I also wanted to just say that the report is available here. It's also on the website, www.futurehealthworkforce.org. Send your friends there, send your colleagues there. In addition to the report, there's a tremendous amount of research and data and information that you might find useful. Today, it's really my distinct pleasure to introduce a colleague, a friend, and somebody who really did put a tremendous amount of himself in co-chairing one of the major work groups on prevention and primary care, but somebody who also, through his entire career, has really represented the best values of California as a clinician, as an educator. And so with no further ado, I'm going to hand it over to my dear friend, Dr. Hector Flores.
Thank you, Sandra. Well, good afternoon. I think in the interest of time, we're all going to stay seated as we give our presentations. Thank you very much, Dr. Hernandez, and thank you to all the foundations for their support. I'm really pleased to be here along with my commission colleagues, and you'll have their bios, more detailed bios in your packet, but I'm going to introduce them in the order that they'll be speaking. That way we can just get right to the conversation. Sitting to my right is Angela Minifield, who is the Vice President of Advancement and Strategic Development and External Affairs for Charles R. Drew University of Medicine and Science in Los Angeles. And prior to that, she was Deputy Director of the Office of Statewide Health Planning and Development. To her right is Jessica Cruz, who's the Executive Director of the National Alliance on Mental Illness, NAMI California, and a member of the Commission's Behavioral Health Subcommittee. My fellow commissioner, Dean Germano, is CEO of the Shasta Community Health Center, which is a large FQHC serving a predominantly rural population, and he'll be speaking to that today as well. And last but not least is our colleague, Dr. Joanne Spetz, who's the Associate Director of Research with the Health Force Center at UCSF. She's been of tremendous assistance to us in our research through her work on the Technical Advisory Committee. I also want to really thank our two project managers who co-directed this, Mr. Jeff Oxendine and Dr. Kevin Barnett. We couldn't have done this without you, so I think we owe you a big hand of applause for the work that you did. Jeff and Kevin really did the heavy lifting to not only do that research and help us put our ideas together, but to put all the materials together, including this final report. So really thank you. And I also want to thank our commission co-chairs, President Janet Napolitano and Mr. Lloyd Dean, CEO of Dignity Health, who really led us through this important work. I'm going to start off with kind of, the overview of our recommendations. We ended up making 27 recommendations, but I'll be highlighting the top 10 that we thought were the most urgent and that would begin to get us to where we need to be. This is a 10-year strategy. It's, as you've seen, the top 10 priorities we calculate would cost us about $3 billion over the 10 years. All 27 recommendations, if implemented and fully funded, would cost about $6 billion over 10 years. And we'll kind of come back to how we would actually work the financing of that. In many ways, we're not starting from scratch because we're actually leveraging dollars that have already been invested in workforce development in our state, as well as private philanthropy. We just heard from them today, and other private sector investors, notably health plans like Kaiser Permanente that's actually building a medical school. Right? So I think we have a lot to build on. We believe that we can eliminate the workforce gaps over the next 10 years, especially on the primary care clinician shortage, physicians, nurse practitioners, nurse midwives, it's PAs, and other health professionals delivering primary care, including behavioral medicine. We were guided by sort of three major strategies. One was to increase opportunities for all Californians to advance in the health professions. It's a litmus test about how we contribute to upward mobility across all communities in the state. Number two, to align and expand education and training to prepare the new workforce to meet the needs of Californians. And number three, to strengthen the capacity, retention, and effectiveness of the existing health workforce to maximize their potential to serve Californians. Ultimately, we made 27 recommendations, but I want to walk through the top 10, and I believe you have a at-a-glance summary of those 10 recommendations in your packet. Number one, we focus on expanding and scaling pipeline programs to recruit and prepare students from underrepresented and low-income backgrounds for health careers. This is part of our contribution to diversity and that upward mobility that we talked about. Number two is recruiting and supporting college students, including community college students, through a California Health Careers Opportunity Program that would link the students who aspire to the health professions with the academic institutions responsible for training them so that we maximize their opportunity to succeed in those pursuits. Number three, supporting scholarships for qualified students who pursue priority health professions and commit to work in underserved communities. Number four, sustaining and expanding the successful PRIME program across all UC campuses. For those of you who may not be familiar with PRIME, it's the program in medical education, which started in 2004 at UC Irvine. And it's an exemplary program that focuses the training of medical students around areas of need. So it actually recruits individuals who have that track record of a commitment to serve those communities and gives them the skills and the tools they need to succeed in the underserved areas and allows them an extra year to pursue master's level training to also embark them on a leadership role that they can play along with partnering with the community that they serve. Number five is expanding the number of primary care physician and psychiatry residency positions. We're really heartened by the expansion of the UC system medical schools and some of the new schools that are emerging in California, including the Kaiser School and soon also the Keck Claremont Medical School. But we need residency programs because a big challenge for us is we could train more doctors, but if there's no training programs for them, we actually then fall short of our mission. And potentially they may go to other states to get their training, and they actually may not even come back to California, which is our goal. Number six is recruiting and training students from rural areas. And again, Mr. Germano will talk about that in a bit. Number seven, maximizing the role of nurse practitioners as part of the care team to help fill gaps in primary care. Number eight, establishing and scaling a universal home care worker program with career ladders and associated training. Number nine, developing a psychiatric nurse practitioner program. And number 10, scaling the engagement of community health workers, promotores, and peer providers to meet the needs of Californians. It's quite a list, very ambitious, but we believe that it will result in some important outcomes, some of which our speakers will address. Notably is that we will be increasing the total number of health workers by 47,000 over the next 10 years. And that includes the spectrum of providers who are not just clinicians, but also supportive services that will allow us to meet the needs of Californians and deliver that care in a way that's better, faster, and cheaper, which is really what we're all being challenged to do. Number two is improving the diversity of those health professions by focusing on recruiting 30,000 out of those 47,000 workers to be for underrepresented groups or disadvantaged communities throughout California, and increasing the supply of health professionals who come from and train in rural and communities, because statistics show they're the ones who are most likely to want to practice in those communities. And all in all, training over 14,500 providers, such as physicians, nurse practitioners, nurse midwives, physician assistants, and others, to meet the needs of Californians. We're going to go through some projections. This actually would exceed our need as we calculate it. And our goal is to have at least 20% of those clinician professionals come from underrepresented groups. So now I'd like to ask my colleagues to really begin addressing some of these areas in a more focused way, and we'll start with Angela.
Thank you, Dr. Flores. Being a part of this work and being at the table today is very important to Charles R. Drew University because it actually amplifies what we do as a university, and we know that we can't do alone. For many of you, you may not know that this university, Charles R. Drew University, has spent more than 5 decades committed to cultivating diverse health professional leaders who are dedicated to social justice and health equity for underserved populations through outstanding education, clinical service, community engagement, and research. We are actually building a pipeline by supporting young people and second career individuals in the greater Los Angeles area, doing an essential part of recommendations 1 through 3, and in fact, a number of others. But again, we cannot do this alone. The demand is significant, and the demand continues to grow. We want to be sure that we all remember the saying, "It takes a village," and urging leaders in all fields, health, education, business, labor, government, and philanthropy, as well as at the local and state and federal level, that we cannot afford to wait to act. We've been waiting for far too long, and as a result, we know that 7 million Californians live in health professional shortage areas today, that we face an anticipated shortage of 4,100 primary care clinicians, and we only have 2/3 of the anticipated psychiatrists that we will need by 2030. We'll also need additional 600,000 home care workers so that our aging population can continue to live a vibrant life at home. This is in large part, again, because we are aging, we are graying, the silver tsunami, if you will, is already here. And California is the most diverse state in the nation. We need a workforce that mirrors California. Over the years, there's been a number of efforts that emphasize workforce diversity, but we're still not there. For example, 40% of Californians are Latinos, and only 3% of California's physician population is Latino. Similarly, African Americans are 6.5% of Californians and only 3% of physicians. This is something that has to actually change. And we know that these gaps, if we don't act now, will be exacerbated. The shortage of health workers from communities of colors in areas that have significant maldistribution, including rural areas that Dean is representing today, Los Angeles, the San Joaquin Valley, the Inland Empire. We have to act. And this report really gives us some tangible things that can be done over the next 10 years to realize that. We know from our experience at CDU, and I'm sure many of you also know this, that students want to serve in their communities. They have the passion, they have the commitment to change the health of their families, their experiences, their economic situations, but it can be a challenge because health professions education and training is costly. This is why recruiting students and providing scholarships and support is an imperative. Loan forgiveness opportunities are an imperative. And to make it clear, we need doctors and nurse practitioners, an array of healthcare workers, including home care workers and community health workers, which represent a team. It's not just one discipline. It requires that we work more interprofessionally to provide whole team care for the community. I also believe that it is important to not only increase access to higher education as an imperative, but it is also essential to make sure that we have a diverse healthcare workforce that can take care of all of Californians. It's not enough to just have insurance and no access, for example. There is definitely a direct relationship between one's educational background and his or her own health status. Every time we support a student's education in the health field, we're not only ensuring that we care for more patients, but that the student is also a patient, and we're taking care of them as well. Thank you.
Jessica.
Well, thank you so much for having me here today. I'm Jessica Cruz, CEO of the National Alliance on Mental Illness California, and for us, we know already, just by our own personal experience as family members, as individuals who are impacted by behavioral health issues on a daily basis, that mental health, behavioral health matters. And we also know that there's a huge treatment gap between those people who are living with a behavioral health issue and those people who are actually able to access treatment. And as you can see by the slide, 62% people need help but can't get it. And there's various different reasons for that, and specifically, it is a part of this workforce. And so being a proud member of the subcommittee of the Behavioral Health Subcommittee, we really balanced the ideas of who needs help versus how can they get help, and all of the different options out there. You know, the Kaiser Foundation and the California Healthcare Foundation just recently released a report that really highlighted the need for behavioral health access, that 9 out of 10 people say that, that it's so important for people to get the mental health treatment and to make it as a policy priority. We also know that half of Californians believe that their community doesn't have enough mental health providers or even services available. And so we also know, as a behavioral health organization, a community-based organization of family members and individuals, that it's so important to connect the community to the treatment. So the individual who's receiving treatment from the traditional medical model, it's also very important for them to be connected to the community. And that is in equal, and as my colleague said, that we have to make sure that we're treating them as a whole and as a team. And so that needs to be both prioritized, not only in resources and funding, but also in the availability of services for them. So we heard that number 5 recommendation is we need more psychiatrists, and that's 100% true. We definitely need more psychiatrists. But we also need those individuals who can connect our patients, our family members, ourselves to the community, because 99% of the time, people who are living with a mental health condition are not in medical treatment. They're in the community. So we need to focus on peer providers, promotores, community-based workers, family members, and really see them as another extension of treatment for our loved ones and for the individuals. So at NAMI and within our local communities, we see that our programs, our psychoeducation programs, our support group programs are very, very helpful in reducing the reentry of hospitalization of our loved ones, from the utilization of services in crisis, whether it's emergency rooms. When you connect people to the community and their families are able to access those resources, and we expand and think of workforce in a different way other than just medical workforce, but really as their partners with the community, then we will have achieved what we're set out to do in this report. And I'm so pleased that the subcommittee on behavioral health, and actually through all the other subcommittees, we really focused on not just the medical professional expansion of workforce, but the combination of the connecting of communities and the individuals with the medical professionals. So We are very pleased with all of the recommendations. We were happy to see that there were the recommendations to expand nurse practitioners, but also making sure that policy priorities to fund and provide resources to community-based organizations and community-based providers to work in connection with and in partnership with the psychiatrists and primary care are a high priority. So.
Thank you. Dean?
Thank you, Dr. Flores. Dean Germano. I live up in Redding, California, and in a rural area, but all around me are what we call frontier areas. So what I'm experiencing in a rural area is even made more difficult the further out we go. We have 3 regions of California that are particularly very short of what they need to serve their communities. The Inland Empire, the San Joaquin Valley, and the Great Northern Valley, where I reside. And this is no small thing. So I was pleased to be asked to be part of the commission, and I think part of the goal for the commission was to bring a rural perspective. And I really am pleased with the final result, because there was a lot of sensitivity to the realities of training. Training that happens in urban areas doesn't necessarily work in rural areas. I just want to make that clear. So there was a lot of attention paid to what are the kinds of things can we do to make training more effective, to get young people, any people, into the training programs up into our areas. So I would say should be a slide back there. Just a little study we did in our county, 2016, and it shows about over 50% of our physicians, both primary care and non-primary care, are over 56 years of age. Roughly up to a third are planning to retire or leave in the next several years. The tsunami is building. We're in a difficult spot already, and this is not unusual for rural communities. This is very much a typical kind of thing. So, necessity is the mother of invention, and we're doing all sorts of things to try to get ahead of this as best we can. But the bottom line is, without the sufficient workforce, you're starting to see real delays in care, a real dependency on the emergency rooms to provide primary care and prevention. You're starting to see healthcare status start to drop. If you look at the healthcare indicators across the state, the ones that public health puts out by county, you look at the bottom 10, 12 counties, almost all of them are rural counties in terms of their health outcomes. So these are really very real impacts on our communities. I would say that some of the other things that we're running up against, we run a teaching health center, a family practice residency program, and there's another graduate medical education program at a Dignity hospital. And between the two of our programs, we graduate about 9 family docs a year. Over the course of several years, we should be able to get ahead of the primary care gap with that kind of generation, but we don't, because we lose almost all of them to urban areas these days. The packages that are being offered because of the shortages way beyond the means of our community. And so here we are spending all this energy to train and not really seeing the benefit from it beyond, obviously, the benefits of the trainees. So we have to do something different. So a big part of this plan has to do with pipeline. How do we identify particularly young people from our own communities, create pathways for them to get into the various training programs, and that's not sufficient, and then work with the training programs to help connect them to our communities. Don't lose them when they leave our communities. Keep them connected. I'm pleased to share with you, we're working with UC Davis right now on some ideas on this, and we're really excited by that possibility, but we have to do more of that. We are also very dependent on our nurse practitioners and PAs. In our northern area, there is no region of California that is more dependent on nurse practitioners and PAs than far northern California. We depend on them. We could not do without them. We have to find ways to make sure they're practicing at the top of their license in a safe and supportive way. My organization, for example, has started up a postgraduate residency program for brand new NPs and PAs. Our practice is more of an internal medicine practice. You can't put a new graduate in there without the proper support. So we spend up to 2 years helping them to be ready for the full scope of primary care practice that we practice. I'd like to see more of those kinds of things out there to help our new nurse practitioners and PAs benefit from that. Telemedicine, a lot of headlines on that. We use it very extensively. We probably do about 200 consults a month with subspecialists from all the way down to San Diego. Great tool, a great complement, but it's not a substitute to having real-life people on the ground taking care of our patients, particularly in primary care. Certainly doesn't help you in any kind of surgical subspecialty. It's no use having somebody diagnose you with a surgical issue down in Los Angeles when your patient's up in Redding, California, right? So it has its role, but it has its limitations as well. And as far as medical education is concerned, a few of us on the commission, not just me, have been really promoting the idea of a Medicaid, a Medi-Cal graduate medical education fund to provide growth and stability to the training programs in the primary care specialties, and I would say particularly in family medicine. There's just not enough. We have to train our people here in California and as many as we can in the underserved communities in which we serve. So that's my spiel, and I'm sticking with it.
Well, thank you to our initial panelists. Love the work that they do, and I thank them for focusing on particular areas of importance to the commission, pipeline and how important that is, the integration of behavioral medicine with the medical model, more importantly with the community and team-based care, and the integration of team members working at the top of their license or their training. This is an ambitious goal, and the tough task of helping us envision how to get there goes to Dr. Joanne Spetz, who's been really instrumental in helping us think about this, making the business case for this, along with sort of the strategies of how we bridge that gap. So, Dr. Spetz, if you don't mind.
Sure, thank you. So I'm here to share why we think these estimates about the number of workers that this ambitious set of recommendations will produce and the overarching set of recommendations will make an incredible contribution to meeting the healthcare needs of Californians. We did this impact analysis in collaboration with Health Management Associates, and by we, I mean myself as well as Janet Kaufman, who supported the management team of the commission, is a colleague at UCSF, and Sunita Mutha, and Rebecca Hargraves. We all worked on this as a group together and shared numerous documents that you can be glad you didn't get to see. So we were asked to look at the numbers really carefully, look at the recommendations carefully. Are these recommendations realistic? Are they aligned with, if I went to a dean of a nursing school and said, so they recommend that you increase your nursing program by X%, can you do that? That they would not look at me in shock and horror and say, yeah, actually we could do that. So we looked at that, we looked at the literature, and we tried to assess how the impact would play out for Californians. So we also looked at the research on the value of investing in the health workforce. So what we really mean by that is when Californians have adequate access to primary care, to behavioral health, and to home care services, and they're supported by community health workers, promotores, and peer providers, will we, as a state, save money? Because I'm an economist. We know that money doesn't grow on trees, and we need to be attentive to the investment of our resources. So as you can see on the next slide, that Dr. Flores referred to the collective set of recommendations leading to over 47,000 new healthcare workers in California. And these are across all occupations. So it is a very large number, but this covers everything from physicians, nurse practitioners, home care workers, psychiatrists, technicians, therapists, across all the professions, because the need for well-prepared and diverse health workers cuts across the entire healthcare system. These professionals all don't work in isolation, so when we think about health workforce, we thought very broadly. The commissioners clearly did, and we wanted to follow that in our impact assessment. One of the outcomes that I am most excited about is that the investments in the physician and nurse practitioner education programs would eliminate primary care shortages. These numbers were engineered by the commissioners to achieve this, and Dr. Janet Kaufman and I had done projections of primary care shortages in California before the commission's work began, and then when the commissioners completed their work, we looked at those numbers and said, wow, this fills it, which is really quite incredible to think about filling this long-standing primary care issue, which we project is only going to get worse as our population continues to grow and diversify. So this would fill that gap, which is just amazing and excites me endlessly. So make it happen. All of these new health workers are very badly needed, but as I said, it's fair for you to wonder if the large investment is going to save money and be worthwhile financially. So as you can see on the next slide, I'm not going to bore you with all the details, but we looked very closely at the evidence of why and how an adequate workforce saves money. And a few examples I can give you. One example would be the investments in the home care workforce through the Universal Home Care Worker recommendation. That recommendation involves education, career ladders, and opportunities to expand the ability of home care workers to meet the needs of those with disabilities living at home. It turns out that people would rather be at home than in a nursing home, imagine that. And it also saves money when people are able to receive the support they need at home. Certainly 24/7 in-home care is more expensive than nursing care, but there are many people who, between their family members and some home care support, could stay at home, but if there is no home care support, their families just cannot do it. And that forces people into institutionalization. So the recommendation around the universal home care worker right there would save money for our private individuals who are paying for long-term care on their own, as well as our Medicaid program through Medi-Cal, which covers a fair amount of the cost of long-term care. Another recommendation example would be in the area of the community health workers, promotores, and peer providers. Those workforces have all been linked to cost savings when they're able to help clients improve their health literacy, navigate the healthcare system, and make empowered decisions about their care. So we know from the evidence that these investments in these specific workforce categories are going to save us money just from that relatively small investment in those workforces. Providing nurse practitioners with full practice authority has been linked in dozens of studies with cost savings primarily due to improving primary care access. When people have better primary care access as the result of both the physician expansion and the nurse practitioner expansion proposals of the Commission, the result is more well-child visits, more vaccinations, fewer emergency department visits, and fewer avoidable hospitalizations. From these examples, honestly, we couldn't add up all the savings because there was just too much literature, and for some of these professions, the literature is still not quite rich enough for us to want to hang our hat on a single number. But just looking at the example of the recommendation about nurse practitioners and full practice authority, we came up with over $2 billion in savings by 2028, just due to fewer emergency department visits and avoidable hospitalizations, including for dual Medicare, Medicaid enrollees and nursing home residents. So just this one recommendation nearly recoups the $3 billion investment, just that one. If you add up all the recommendations together, we would absolutely surpass that investment of $3 billion. So the sticker shock is kind of, $3 billion is a really big number with a lot of zeros. But we would recoup that with these investments, which is why it is so important that we move this forward.
Thank you very much, Dr. Spetson. Please join me in thanking the panel for their presentation. Before we get to Q&A, and we want to definitely hear from you, I wanted to ask the panel if there's any initial reactions or additional comments they would like to make. No? Okay, well, thank you very much again. There's a mic in the middle here, or at least there will be in a second. And what I would ask that you identify yourself, and if you're representing an organization, also indicate that. Please focus on your question. We want to hear from as many folks as possible. And if you want to address your question to a particular panelist, please feel free to do so. I think we're going to set up the mic, and feel free to line up if you have questions to ask. Oh, yes. Yeah. Two other things while we're setting up. There are comment cards that were on your chair. If you have comments where you want to elaborate on particular topics, feel free to fill those out. The other thing is we do have a hashtag that we'd like you to check out. Hashtag, and it's up here on a placard, hashtag CA Future Workforce. And we also have a website, which is www.futurehealthworkforce.org. And we'll come back to that again towards the end. But definitely would love to hear your comments through these comment cards and also your questions. So we'll invite folks to come up.
I'm Tommy Whitlow, and I only have this question because my brother-in-law was ill, and a health worker came to help them. And my sister refused her, and so did my brother-in-law, because she didn't understand them. At least that's what they told me. So I'm hoping in the process of saving $3 million that the work people that you send out to help the people who need the assistance will be culturally competent, and that you won't send people who say, oh, your house is very nice, and that's not what she was there for. And it was really to relieve my sister, and she wouldn't leave the house, and they were glad that she didn't come back, and I felt very badly about that.
Thank you very much for your comment. Joanne, you were part of the Healthy Aging subcommittee. Maybe you want to comment a little bit about around that.
Yeah, absolutely. The Healthy Aging Subcommittee spent a lot of time talking about home care and cultural competence because, as one colleague of mine who's at Stanford calls it, not only do we have the silver tsunami, it really is a silver-brown tsunami with an increasingly diverse older population and an increasing diverse workforce that is available to care for that population. So one of the universal home care worker recommendation includes training and education opportunities, along with rewards for individuals becoming more expert at their home care work, because it is, in truth, a pretty highly skilled job, although often people describe it as unskilled workers. So, I'm totally in line with you, that education, that knowledge as a home care worker of how to work with a client effectively needs to include cultural competence and being able to work across different kinds of economic, cultural, and backgrounds, and physical needs and emotional needs that their clients have. So, totally agree.
Angela?
I would add that those community-based experiences are essential while students are in their training as well. It's not enough to just train them in the classroom and in clinical settings where they're not interacting with a diverse patient population or an aged patient population. The curriculum also needs to be integrated to include community experiential education, and that's something that we've done at Charles Drew University for a long time.
And you'll notice as you read through the report that the social determinants of health, cultural proficiency, language proficiency permeate through all of our recommendations. So thank you. Yes, sir.
First of all, I just want to say thank you. It's an honor to be here and inspiring, incredible work. So thank you. My name is Matt Pierce. I'm the co-founder and CEO of a company called Trusted Health. And my question is ultimately, I guess speaking of hashtags and websites, we're very close in proximity to, I would say, the capital of the world from a technology perspective, and quite frankly also from a capital perspective. So how are you looking at that as a part of your strategy, from technology, at the utilization of that, how to connect ultimately patients with clinicians, as well as how are you involving more of the Silicon Valley personnel from a capital and financing perspective?
Thank you. Anybody want to?
Well, we did talk about it, the role of technology in this space. How will it change? We're only looking out a few years. Who knows what technology is going to look like 10 years from now? In rural areas, there's potentially a great application for this. The one limitation is high-speed internet, which is lacking in many parts of rural California. Hopefully that will change. I'm assuming the technology will change and that might be overcome. But I think the other piece to your question is how we change the reimbursement of health care. Because right now everything gets driven through the doctor, the nurse practitioner, PA, and it really limits the models upon which you can work from. I think if we change it to more a value-based payment system where we can start fully utilizing the skills of other providers, then home care kinds of things, and then teleconferencing, and then the nutritionist or the diabetic educator or other pieces of that can work together. I know there's diagnostic tools you can keep. I've been to one of these high technology, I'm Italian, I use my hands a lot, these sessions where they go, and we have all these diagnostic tools, and it sends all this data, and it pushes it out through the internet, and then it goes to your doctor. And I'm on the doctor side, and say, what do you think the doctor's doing with everything your mom and dad did for 24 hours? You have to think it through to a more practical level, but I think the opportunity is there to really leverage the technology when I think our models change. That's just my opinion.
And if
Go
I
ahead.
can add, we talked a lot about it in our behavioral health subcommittee as well, because just accessing behavioral health care can sometimes have barriers just in and of itself of somebody walking into behavioral health and the stigma around it. And so there was a really good conversation about how do we connect telemedicine in other areas that there's a lot to do with like behavioral health apps and counseling and connecting people. And I think that you hit it on the head in a lot of ways. It's connecting the billing of the doctors. It's getting the professionals to understand the technology outside of the world that they're currently in. And then I think that there comes with some pros and cons, especially for behavioral health, in when you're accessing somebody who's on the other side of an iPad or a phone, and you may need crisis. How is that person then going to connect them to the services within their community? So I do think that it's a discussion, at least in the behavioral health world, that is being had because we need to break down those barriers when it comes to stigma and people accessing it. But I don't know with this report and what this commission is doing, if we've thought through that piece yet. But I can tell you that it's on the brink of at least the behavioral health world and what we're in. So.
Yeah. And thank you for your question. I would add, one of our recommendations is to establish a California Health Workforce Technology and Data Center to help us sort through all the opportunities that are out there, not only in telemedicine, telehealth, but digital health. And we know that there's a digital divide, but fortunately it's getting narrower and narrower. Oftentimes it's the adult children of the elder patient who is advocating for them through that mechanism, as well as telecommunications and health information exchange. And this center would allow us to begin to be that clearinghouse so that we get best practices and not waste our time or money with that dead end components. So thank you. Great question. Yes, please.
Hello, my name is Juan Flores. I'm a community health worker from Valley High School. I'm also an intern at One Community Health. And my question is regarding the community health worker and promotor priority. And my question is, how can we clarify how community health workers and promoters work, and making sure that they're not stepping on anyone's toes, and that we clarify, their role in a multidisciplinary team?
Great question. Well, I can tell you from my own practice, because we train promotores and they're part of our practice, and it goes along what Dean and Jessica were talking about. If we change the way reimbursement occurs, this is why I'm a big believer in capitation, HMO medicine. Kaiser's a very good example of an excellent system. When we get prepaid, then this whole idea of turf and who delivers what service goes away. And I remember, and I'll give you an anecdote, when I was a medical student, an ophthalmologist came and said, how many of you are going into family medicine? So I raised my hand, foolishly, because I didn't know I was going to get beat up. And the ophthalmologist says, you have no right to see the red eye because that should be seen by an ophthalmologist, right? So I got all scared. Never mind that 99% of red eye is conjunctivitis, simple infections that a primary care clinician should be able to manage. I get to Kaiser for my residency, and the ophthalmologist comes and says, red eye is your responsibility, and you should only triage the things that are serious red eye complications like iridocyclitis and all these other things. And I saw the wisdom of prepaid medicine. All of a sudden, those turf issues go away because everyone's rowing in the same direction trying to accomplish that. So part of our proposal is to have certification of the training programs for promotores, not the individual, because that can become a barrier that really prevents them from being deployed and doing the important work they do. But the certifications that we can have standards, and part of those standards is to make sure that they are not inadvertently dispensing medical advice or practicing medicine, but that they know their limitations. But the wisdom of all of this is by having that standardization, we embark them on their own upward mobility. We have a current medical student who started off as a teenager promotor just like you. And he was so engaging with patients, caught everyone's attention. He's now a third-year medical student, and I'm hoping he'll come and do his residency with us. But it's about also helping them along their own upward mobility. So thank you for your question. That was great.
And I have a second question
Sure.
for Jessica. My question is regarding behavioral health, and if there's any, potential of clarifying what a moderate to or a mild to moderate patient looks like, and a moderate to severe patient looks like for how primary care physicians refer to behavioral health services, and just clarifying that whole narrative.
I think that that is a question that needs to be unfolded, and I don't know if we even have the time, because I know that when we talk to Department of Healthcare Services, you know, they're doing a big project right now on clarifying the mild to moderate and those who are maybe in severe crisis, but I think that could be maybe an offline question that you and I can maybe talk about, or even some of the people here that have more research and things, but there is a lot that's being done, and it's definitely something that needs to be clarified specifically for reimbursement and everything when it comes to actually providing the care that these individuals need, and when it comes to prevention and early intervention on those people with mild to moderate, and making sure that they don't get to the heavy piece of crisis. So, sorry I couldn't answer it more fully.
Greetings, my name is Chris Ryther. I'm a professor at American River College. I'm also still a per diem paramedic for Sierra Nevada Memorial Hospital Ambulance Service. And since less than 7% of 911 calls are for life-threatening conditions, the California Healthcare Foundation has about 40 articles on their site about community paramedics. And OSHPD has completed trial programs of mobile integrated healthcare. Does the commission support legislation to enable community paramedics? And it's a model that's in many places across the country. It's something that is predicated on the idea that a needs assessment is done in the community and that they don't duplicate or compete with other services. But in my practice throughout my adult life, I've dealt with a lot of patients that should be getting different services, and they're not. They're going to emergency departments instead. So if anyone wants to address that.
Well, thank you for your question. So legislation was beyond the scope of our charge, but we can certainly make recommendations. Our belief fundamentally, as you read through the report, is we need all hands on deck, and we need to be able to facilitate the areas where that collaboration needs to happen, especially at the community level. There's very good models that are emerging around EMS delivering services and other similarities. So I think we need to push that envelope a little bit more, but it really will entail legislation and regulation that we felt was beyond the scope of our charge.
This workforce is already in the field right now.
Yes.
I just wanted to add a piece. I think certainly in rural areas, they're already pushing the envelope and taking care of a lot of people. I would say that for me anyways, personally, the key to that is how connected they are to the other resources in the community. If there was a system by which the paramedic did that treatment and then connected them to a primary care practice for the follow-up, I think that makes a lot of sense than just a silo kind of encounter. So I think that would be key, is how we connect those pieces together.
I think that's being done in many places, and I think the technology, even in the rural area where I practice, still allows that to happen, especially discharge planning and medication reconciliation, and many other kinds of things. So, thank you.
Yeah, thank you.
Hi, Paul Curtis with the California Council of Community Behavioral Health Agencies. We represent the nonprofit agencies across the state working in behavioral health. Workforce development has been the top issue for our members from the beginning. It's huge. They cannot hire the people at all levels, not just the licensed professions. At all levels, they can't hire them and keep them. It's preventing them from fully utilizing the funding and providing the services that they want to provide across our state. I was curious, especially in the Behavioral Health Subcommission, did you look at the possibility of the creation of a career pathway? It's something we're advocating about. The nurses 15 to 20 years ago had a huge shortage, and one of their main projects was creating a real career pathway. For instance, we have some health professions high schools, including one in Sacramento here, but they too often focus on the physical medicine side and not on the behavioral health care side. So there's a real lack of awareness across the state of the availability of professions within the field, and it's one of the big issues we face. I certainly hope that's something, I would assume this was discussed, but I was curious about that.
Yeah, absolutely, and I know Jeff can speak to it more, but we talked about that at length, and there are some recommendations within the 27 that talk about, expanding CalHOSA with the youth within CalHOSA to continue their mental health curriculum. But Jeff did an amazing presentation on a pipeline program and how it works. So.
We definitely, across all the different professions, prioritize developing career pathways and building on those that are already in place. For behavioral health, as Jessica said, there is a recommendation that is about building through HOSA, building statewide, building high school pathways to behavioral health careers, as well as informing young people about taking care of themselves with behavioral health. That we also have a college behavioral health pathway that's part of the recommendations, as well as a new innovation to increase access to care for college students around behavioral health. And then our Health Career Opportunity Program, that's one of the top recommendations, and the expanding the current successful pipeline programs. All of those can have a behavioral health focus as well. So it's definitely a top priority. As Hector said, one of the themes is having more people from California be able to have opportunities to be in these rewarding, needed professions, and I think that's a core throughout all of the different recommendations. Thank you.
Thanks. And a quick question, a second really quickly, a comment as much as a question. When we're talking about behavioral health care, to make sure we include substance use disorders and services, fully understanding why Jessica would call it the mental health, because it's NAMI, but there's still a division within our community, and it creates a bit of a stigma. And there's just as much of a need in the substance use disorder sides for workers, for peer counselors, for the whole bit. We have a huge drug situation in our state, not just with opioids, it's everything else as well. And it needs to be a cohesive and inclusive approach and all that. And I know that's not what you're implying. I continue to try and call it out on behalf of our members to make sure that we're all aware that it has to be a real inclusive approach. Thanks.
Thank you.
I'd just like to add just one little piece to that. In a lot of primary care practices in the community health center world, we've developed models of integrated behavioral health and substance abuse in the primary care home. And it's been highly effective. Our biggest issue is scaling it. And that's the biggest challenge. But early indications are really the return has been remarkable. So.
I'm Abby Snaim, the CEO of Jewish Vocational Service in the Bay Area. We do extensive training in healthcare with most of the major medical systems in the Bay Area, and I was privileged to be part of the technical advisory committee. I have a question and then a comment. With the emphasis, and such a strong and right emphasis on primary care, I'm wondering how the need for medical assistance emerged, and frankly why it wasn't part of the top 10 recommendations. We just hear consistently from primary care systems who are developing and saving money and having better health outcomes with team-based primary care about the critical role of the medical assistant. So how did that emerge in the discussions? Or not? Yeah.
And actually it did. Thank you for your question. It's part of what we believe can be leveraged rather than, say, us recommending, because most of the practices are understanding, A, they need the medical assistant. It's an entry-level position that also allows that person to advance. But number two is, as we look at certification, for example, for patient-centered medical home, or simply the aspirational goal of being PCMH certified, allows practices to develop their MAs along what we call advanced MAs, where they actually scale up their skills, means they get better pay and also ability to manage together with the physician and other clinicians, the patient population. So we felt that was already baked in, but that what we needed to do was highlight the other professions that are sort of being forgotten and implement them first. Clearly, medical assistants, clerical support and other kinds of professions are going to be needed, and we thought that those were baked in at the beginning.
Yeah, I appreciate the attention you gave to it. Bear in mind that the training system for MAs is grossly inadequate. Yes. Both in just the reliance on the private proprietaries and the length of training in the community college. So there's some training solutions. And on training, just a reminder, and I know this is embedded in the report, but we'd love to talk about high school students and creating pipelines for youth. Remember that 2/3 of the workforce we will have in the next 10 years is already in the workforce. And so we just want to look at pipelines from people in low-wage jobs and other kinds of careers to get them into healthcare.
Absolutely, and one of the things that the sort of cross-cutting committee of UC, Cal State, and community colleges looked at was this opportunity with distance education through the online course initiative, and also identifying these entry-level positions as viable majors. We like to say we left a lot of things on the cutting room floor. One of those was a universal pre-health curriculum that would be adopted across the state so that students, re-entry students, non-traditional students, as well as students coming out of high school could benefit from that curriculum, and an employer would actually already know what the curriculum covers, so they have an expectation of what they need to do on the job training and what they already had before. And it allows it to be modular, so a student can actually take time off work and then re-enter the school system with a consistent message. I know Jeff and Kevin have done some work with Pipeline, and you may want to talk about that. I don't know if you want to add to anything we said already.
Sure. I would also just say that we did address medical assistance as part of primary care transformation, which we said was part of one of the essential conditions that needed to take place. And medical assistant and community health workers and home care workers, other frontline workers would all be part of building these pipelines that start in K through 12 and include community college and four-year college and on up. So that will definitely be a focus.
And I would add another pipeline in is the public and community-based workforce system.
Absolutely.
Okay, great.
Absolutely.
Thank you. The other item related to this, and to the earlier questions on behavioral medicine, the philosophy that we adopted in the commission was that when we practice in a community, obviously the relationships with the community as much as it is with families and individuals, but our pipeline is our patients, and our patients are our pipeline. And so our obligation is to reach out to everyone in that community and engage them in their own health, engage them and provide the opportunities for them to enjoy a healthy life. And that includes the behavioral medicine component, helping them access the services they need. Those of you who work in pipeline programs know that when you're working with disadvantaged students, often behavioral issues are a major barrier to their learning, and so the sooner we address that, the better. So thank you. Please.
Hi, I'm Gina Ariel. I'm a certified nurse midwife, and I'm here on behalf of the California Nurse Midwives Association. And I just wanted to thank you for including certified nurse midwives when you talk about advanced practice nurses and nurse practitioners. And I just wanted to reinforce the role that nurse practitioners play, and certified nurse midwives play with nurse practitioners in primary care and also in mental health in terms of postpartum depression, identification, treatment, referral. I was wondering how you, and I was really very happy to see your focus on working towards full practice authority for nurse practitioners and nurse midwives. And I was wondering how you see that coming about outside of a legislative push, or perhaps how do you see your role in pushing that legislation? And I just wanted to also ask why, or if you had thought about why you didn't include sexual and reproductive health in looking at this.
Well, thank you. I think maybe several of us would have comments, but so sexual and reproductive health we felt was also part of the charge of delivering the services that are comprehensive, primary care, prevention-oriented, and also integration with behavioral medicine. What we didn't want to do is get into a long checklist of things that we thought should be included, because then if we leave something out, it doesn't mean that we don't think it's important. So that's part of the reason we took that. To your earlier question, certainly legislation would have to be introduced to kind of ease the regulations and some of the angst that people who otherwise would support independent authority would have. Personally, again, my example of Kaiser, right? When I was at Kaiser, I trained at Kaiser. My obstetrics experience was largely taught by nurse midwives, and it was not an issue of turf anymore. It was just the competency. And so we had nurse midwives who had practiced for 30 years and actually knew how to do operative stuff really well. So to me, alternative payment model is a way to get away from legislation, because you automatically align the incentives around everyone working at the top of their license and training. In other areas, obviously, there will have to be legislation, and some of the things we're going to be working on is how do we get to that point. And you know, I'm a physician, I'm a family physician, and you know, in my specialty, we had to fight for our right to practice our trade, right? We had to show that we were competent at providing obstetrical services and surgery. So we understand exactly where nurse practitioners, nurse midwives are today. But we also have to go through the route that we went, where we had to demonstrate our competency so that the public would feel confident. You know, so I think that the track record of organizations like Kaiser, track record of individual practitioners, is going to be really helpful to us to make that case.
Yep, I'll add to that one of the recommendations that, you know, we didn't give you the gory details of all of the sub-recommendations of the top 10, but one component of that also is to try to bring together a committee of organizations and healthcare systems to look at the barriers that they have in place that are more restrictive than what the law currently allows. And we have seen this, it's been documented as a national issue. Almost no matter what the state's scope of practice regulations are, you will find organizations that are more restrictive than that. So even without legislative action, which of course one of the recommendations would require legislative action, even without that, there is an opportunity to, and I think an imperative, to bring together organizations and help them understand the benefits of embracing the fullest level of training that they are legally allowed to put forward, or, you know, to have all of their healthcare providers do in order to meet the needs of their patient population. So, you know, we could get, even if the legislation passed, the organizations still have to adopt the change themselves. So that's part of the overall recommendations, I think a really important piece that's easy to overlook.
Thank you.
Thank you for your question. Hello.
Hi, my name is Sarah McGinn. I'm from SCIU Local 1000, which represents about half the state workforce, including registered nurses and allied healthcare workers. And I really have a comment. I wanted to thank you for the proposal you guys have put together in the report, and I like the focus on rural communities and underserved populations. One thing we've worked on here at Local 1000 is innovative apprenticeship models. And the great thing about earn and learn models is that those from underserved populations often can't afford to leave the workforce to go pursue, you know, career development and education. So I wanted to share just a program that we just got awarded funding for on Friday, which is an LVN to RN apprenticeship program. We partnered with California Correctional Healthcare Services, right here, Riverside City College, and then Local 1000. And the grant is for to have Riverside City College deliver the curriculum to LVNs that are in Tehachapi and Blythe, and give them time off work, 20/20 time, to pursue the program and pursue the RN degree, and hopefully we can make it kind of a long-term program. So something new and different I just wanted to comment on. And I want to thank Joanne, because we cited a lot of your work in our grant applications. So thank you.
I'm familiar with that program. It's super cool. It's a great, I mean, I think would easily fall into some of the pipeline recommendation categories that were within the overall report. But yeah, it's a great program.
Thank you.
Thank you.
Hello, my name is Shakira Fangonilo. I am a certified community health worker at Valley High School, and as well as an intern at WellSpace Health. We want our physicians to focus on holistic health and to have important skills such as cultural competency, which community health workers possess. So how are we going to facilitate the process of incorporating CHWs into medical school curriculums, and have medical schools considered partnering up with community health worker programs to have culturally competent physicians?
Can you repeat your question?
Okay. How are we going to facilitate the process of incorporating community health workers into medical school curriculums, and have medical schools considered partnering up with community health worker programs to have culturally competent physicians?
I don't think I have the direct answer, but what I can say is that I know that community health workers are working with our public health providers, led by Dr. Hector Balcazar at Charles R. Drew, as a way of training future public health practitioners about how to integrate themselves into the community. And so that's just a model that has just been funded. But in addition to that, at CDU, we have what we call the CDU Advantage. And so the curriculum has 5 elements: global and international health experiences, again, community-based experiential education, health policy, research, and also a focus on social justice. And all of those elements were really sort of born out of the experience of our university being one that is community-founded and really focused on serving underserved and under-resourced communities. So I know that's not a direct answer to your question, but that's what we have.
Okay, we have a comment from Dr. Burnett also, and I just want to advise the people who are lined up, you'll be the last question that we'll take today in the interest of time, okay? So thank you. Kevin, did you have a?
Hi, Kevin Barnett, Public Health Institute. So one of the elements of the recommendation around scaling the engagement of community health workers, in fact, involves engaging community health workers as a part of the health professions education process in medical schools and others. And this speaks to the broader set of 27 recommendations, because there's another recommendation that focuses on integrating fully the knowledge of the social determinants of health across health professions education institutions. And clearly, community health workers have an important role to play in that education process. Kaiser Permanente in Southern California already engages community health workers as preceptors as a rotation for their primary care physicians in the process. So there's this work, and there's work that is already going on in this arena, but clearly we have an important role for community health workers to play in helping to strengthen health professions education, and it is a part of the recommendation.
Thank you.
Hi, my name is Jane Adcock. I'm with the California Behavioral Health Planning Council. I did participate on the Behavioral Health subcommittee, and I have to thank you all for this product. I was in awe at the level of knowledge and expertise that was brought to the table on our committee. My question is, how or who will nudge these recommendations forward to fruition? If you could speak on that at all.
Well, great question too. Thank you all for asking a fantastic question. Part of this will be, obviously we have a great opportunity. One of the things that commenters as well as commissioners have recognized is we have a new administration, wants to move on universal coverage. Obviously, covering people and having no access doesn't solve the problem. So I think we're going to have a receptive audience in the new administration. Again, we've had major investments over the years in workforce development, so that also gives us the confidence that we're actually going to be able to have many of these recommendations implemented. Many of the folks who were on our commission were champions of many of these ideas, so they came in with those ideas. Some of them were legislators, so we're confident that legislature will also step in. And the funders, I mean, they have spoken with their money and their commitment. Clearly, Dr. Sandra Hernandez has a ton of things that she could be doing today, but she's here and sitting with us through the whole to hear your questions. So I think it speaks volumes. And the industry is another area that, again, there are leaders like Kaiser, Sutter, Hill Physicians, Healthcare Partners, which is now part of Optum, that are actually investing dollars in workforce. I think part of our challenge is being able to have an opportunity to coordinate all of that. And part of what we're hoping the governor will do is actually look at how to organize that through either the Office of Statewide Health Planning or a different mechanism, but getting us to that point of everyone rowing in the same direction.
I would
Kevin?
just add that, yeah, it's going to take a village to push this agenda, no doubt, but we have that village. And I would also say that if you think about the top 10 recommendations, you're talking $3 billion. That's roughly $300 million a year over 10 years. I got to think in the state of California, we can muster that kind of energy around that. So I'm optimistic that we're going to be able to do some good work here with the right partners.
Yeah. As an employer that offers insurance, because what we're proposing is $300 million a year, which is about 1/10 of 1% of what we spend on healthcare every year in California. As an employer, I'd be happy to say for every $100 I'm paying for healthcare insurance, I'd be happy to contribute a dime and more than that towards the solutions that we're offering here. It's that small of an investment, relatively speaking. Kevin, did you have a comment?
Yeah, just a quick follow-up to, I think this both addresses some of the elements that folks have identified that maybe I didn't see this in the plan, as well as the issue of how we go forward. As you'll see in the report, this is framed as a 12-year implementation process, and while the commission is no longer engaged, the intent is to establish a state infrastructure to ensure the implementation of these recommendations. And you'll note as you read through the 27 recommendations, they're highly synergistic. They're intended to be mutually reinforcing. So it's terrific that we already see a number of folks stepping forward to say we're going to advance this recommendation in the policy arena, but we look at this and hope that folks will look at this as a package of recommendations. Almost a year ago in this process, we had 171 recommendations. So it's a good thing, we believe, that we're down to 27, but there are issues relating to physician's assistants, dental hygienists, where's oral health in this there, that will and should be taken up as part of this implementation process through that infrastructure. So we hope folks will stay engaged in looking at how to advance the things that may not capture what you feel are some of the most important elements. So,
thank you.
Well, thank you for your work. My name is Vicki Vinker. I'm the director of the California Health Reform Initiative of Convergence Center for Policy Resolution. I'm very heartened to hear about the work around cultural competency and increasing racial diversity in our workforce. I'm wondering, in terms of looking at attracting people to the workforce and supporting them through it or transitioning within it, if there was any look at gender bias and, supporting men who want to be RNs, women who want to be surgeons, that sort of thing, because it seems to me that might expand who would come in and get trained.
Absolutely. I think that's something we championed from day one. The sort of three principles we work with were diversity, equity, and using technology to enhance access to education. And part of that is the gender equality, not only at those levels that you described, physicians, health professionals. Fortunately, in medical schools, now there's more women than men, so that trend is changing, I think, in a very positive way. But also the entry-level positions and making sure that they're well paid. We talk about burnout amongst physicians, et cetera, but nobody's paid attention that we've had burnout in the entry-level workers for many, many years because they're just not paid enough. So I think that those are the kinds of things that underline and underpin our recommendations. So thank you for bringing it up. Appreciate it.
Hi, my name is Marissa Gonzalez. I'm with the National Association of Social Workers. I had a question regarding the pipeline system. So understanding just becoming a doctor, you typically need to get a 4.0 GPA from high school and then try to get into a good school and go through that. So my question is, for the low-income communities, for students who don't have parents who are aware of tutoring systems, who maybe don't even speak English, who can't provide that guidance and maybe even don't know what FAFSA is there a look into middle school, elementary school pipeline systems for students who may want to be nurses, doctors, go into those really difficult fields, but they just don't have that guidance or the parental support to succeed necessarily. And so you usually have the 1% people who just are naturally highly gifted who can succeed, but then the other people who are willing to work really hard but may not succeed at the UCs. And so that's kind of like my question, is there a focus on getting those kids kind of recruited from that?
Absolutely, and maybe Angela can talk about the uniqueness of Charles Drew. Let me just make a quick comment, sorry, but that what you just articulated as part of our challenge is that you don't need to be a 4.0 and perfect MCAT test course to get into medical school, and yet a lot of our students, especially disadvantaged students, are being told, if you don't have that, don't bother applying. So we need to dispel that myth, and really that's a segue to what Charles Drew does, I think, to reach out to those special students, and then I know Jeff wants to make a comment as well.
Yeah, we have a pipeline program that has been in existence for over 20 years called the Saturday Science Academy Pipeline Program, and it's been funded by people in this room, including the California Wellness Foundation, but specifically, it targets children as young as 4 through 18 and provides them with an array of experiences, exposure to math and science that are foundational to one pursuing a health professions education and training, but it also engages their parents. It also provides tutorial support. It also provides mentoring and advising from students that are at the middle and high school level. So, you know, to your point, not every student may have a 4.0 GPA, but they have the persistence, they have the grit, if you will, to pursue a health professions education and training, but they need those wraparound supports. And parents are an essential element to involve throughout their pursuit of a health professions career.
I would just add, in the community health center world, we are more and more embracing our own patients and their children and saying, have you thought about being a nurse? Have you thought about being a doctor? Have you thought about being a social worker? And putting the thought in front of them, and then I think what we're missing is the wraparound supports for them. But we are developing what's called these hometown programs, where we identify these young people and we help to nurture them through and get them through, because ultimately we want them back to serve our communities. So I think to us that's really the goal, and we're trying to build towards, and it was reflected in some of these recommendations.
Yeah, there were a number of things in the report that referred to pipeline development as well.
Of course, 3 strategies is increasing opportunity for people from our communities to be in these roles. And in our report, the pipeline really ranges from K through 12, community college, 4-year college, post-bac, health profession school, residency. It's really having a linked continuum of support across those levels, and including the academic support and the parental engagement and career support and better advising and mentorship and those things. So that's the recommendations that include expanding the pipeline programs that we have. We're fortunate we have really great pipeline programs in California. They're just not scaled and sustained, and so that's part of it. And then building the health career opportunity programs at the college level, building the post-bac programs. We have a number of recommendations that, as Kevin said, are mutually reinforcing to make sure that we build that pipeline all the way to back to employment in the communities.
Yeah, thank you for your question. That part of our goal was to figure out ways to create a culture of achievement in the communities that we serve, and to provide that career ladder perspective that, you know, they can succeed incrementally. Some may actually leapfrog into a career very quickly, but that those opportunities will be set up, that there will be milestones that they can achieve and feel confident that they will ultimately get to their dream. The other piece is we need to focus on who's getting recruited and accepted to these training institutions, because we hear a lot of complaints from patients, and that's one good thing about value-based pay for performance, right? We're hearing patient satisfaction surveys, and they say doctors need better training at the humanistic skills, and so it begs the question, are we actually inviting the right people to be trained, and are we training them in the proper way? And so I think there's some good models like the PRIME program, the Kaiser Medical School vision, you know, is to radically change the way physicians are trained, more on the patient-centeredness and the cultural proficiency and learning tools for language access. Well, we want to thank all of you here. I know Dr. Hernandez has some closing comments, but really want to thank you for your wisdom and look forward to more of your comments, because this is a learning community that we want to establish. So thank you for being here today.
Help me thank the panel and Hector for great moderation. Really appreciate the very thoughtful questions. If I could sort of pick up on sort of 3 things that our panelists said this morning, because I think they really are what will be sort of the principles as we go about realizing this plan for the state of California. One that Hector said, which, you know, I think is just worth noting, we need every drop of trained workforce that we have in the state. And this is really an opportunity with this report to look at science and look at what's possible and look at what tremendous gaps are, and really kind of put down the barriers and really say, how do we use all the capabilities that we have? So I really wanted to call out that point. Joanne has done a tremendous amount of work on the impact assessments along with HMA, her team, and I just wanted to say, you know, $300 million a year over 10 years really is not a massive amount of money. And one of the things we know is that the way we do budgeting is we tend to budget year by year. What are we going to pay for this year? What are we going to pay for next year? What I think this report largely asks and calls for in all of its recommendations, not just the 10 that were called upon today, is that we actually think about this as a forward pay. We really do need to think about the future and what the investment's like. This is California. It's an amazingly diverse state. We have an elderly population, and we really ought to start making those investments now. And as Hector and others said, it will take all sectors to be able to do that. And I'll maybe end on Dean's note, which is that he's an optimist, as am I, and I think everybody who worked on this work is and was and will lean into it, and we hope that all of you will continue to be engaged. We will have another couple of these type of briefings. We're going to do one next month in Los Angeles and then one in April in Fresno. We encourage you to go to the website, follow along, join those, encourage others to do it. We highlighted 10 recommendations today. As was noted, there were many more in the report and sub-recommendations, and so I urge you to take a copy of it and help us realize this incredible vision. Again, thank the panel for being here today. Thank you all, Hector. Great job moderating. Appreciate you all being here. Thank you. Bye-bye.